Welcome back to our next section, valvular heart disease. Makes you short of breath, doesn't it? Yes. Now let's see. Mitral stenosis. Mitral stenosis. What's the most common cause of mitral stenosis? Would that be? Yes, it is rheumatic fever. Therefore, the mitral stenosis person, most of the time, is going to be in an imported person. It is going to be in a person who is an immigrant. Why? Because acute rheumatic fever is almost exclusively a non-domestic disease. This is, after all, USMLE, which means that once your per capita income goes up about $5,000, what that means is that your rate of rheumatic fever goes to nothing, tuberculosis to nothing, syphilis in large part to nothing. The best way to help raise the health standards of the world? 1 billion people living on $1 a day? 2.7 billion live on $2 a day. If you could get that to be $5 a day, most of these diseases would cease to exist. If you can get the average, the lowest end of the world income to $5 a day. In other words, rheumatic fever is virtually non-existent here, so mitral stenosis is an imported people. Now, if you don't know why to blame a problem on, but you've got a problem, and you say, I've got a problem, it can't be my fault, who do you blame it on? Parents. Why do we have relationships? In order to have someone to blame. Now, let's see. 2/3 of patients are female. Also, well, that's a little skewed. Females come to attention for symptoms earlier. Why do females come for attention for symptoms? Because I may be juicy and full of life, but I'm never getting pregnant. No matter how juicy and full of life Dr. Fisher is getting, I'm not getting pregnant. And women who get pregnant, you see that stenotic thing? You're going to look for the pregnant female, because what happens is you have an increase in 50% in plasma volume. And what ends up happening? You have a stenotic orifice. Look at this stenotic orifice. Oh my, what a tiny hole. Oh my, what a tiny hole there is there. Yes, that does look tight. Yes, and this woman has got herself an increase in plasma volume of 50%, but the mitral stenosis hole is staying the same small size, so it doesn't fit too. And that's for the pregnant woman. You've never been so juicy as since you've been pregnant. You've never been so ripe. You've never been so ready to drop like a big fruit. But your mitral valve won't let the fluid through. So what happens to you? You get short of breath. Oh, that's all valvular disease, isn't it now? You get short of breath. That's all valvular disease. You get tired. Well, if blood won't go forward, you get tired. Now, anybody who has a stenotic lesion will have hemoptysis. Aortic stenosis also gives you congestive failure and shortness of breath and hemoptysis. Hemoptysis means you're just coughing and you're a little too juicy. Hemoptysis. Now, embolism. Why do you get an embolism? Well, this is the first thing that we have here, finally, that is unique or more predisposed to in mitral stenosis. Why do we have the greatest amount of embolism? Because we have the largest left atrium. And since we have the largest amount of left atrium, we have the largest amount of AFib. And since we have the largest amount of AFib, we have the largest amount of strokes. So therefore, we have the largest left atrium, the largest amount of AFib, the largest amount of strokes. This is the first thing that's unique for mitral stenosis. What's different? What's unique? I want to answer the question, which of the following is the most likely diagnosis? I want to answer the question, which of the following is the most likely diagnosis? They all make you short of breath. Aortic stenosis makes you short of breath. Mitral regurgitation makes you short of breath. Aortic regurgitation makes you short of breath. What's different? What's unique? What's different? What's unique? Largest amount of left atrium, largest amount of AFib, the largest amount of stroke is a person who has mitral stenosis. What else is different? Hoarseness. Why? Because that big left atrium is pressing on the recurrent laryngeal nerve. That big left atrium is pressing on the recurrent laryngeal nerve. That big left atrium is pressing on the recurrent laryngeal nerve. Okay? big liver, big edema, big heart, shortness of breath. The other thing is you're going to also look for dysphagia because the big left atrium is pressing on the esophagus. This is a lateral chest x-ray, and this is the heart. The heart, the most posterior structure in the heart is the left atrium. As the left atrium enlarges, it enlarges backwards and presses against that esophagus. So that what is different about mitral stenosis from all the others? Hoarseness, AFib, strokes, dysphagia, and also, which of these is in a pregnant chick? Only mitral stenosis. You get your rheumatic fever when you're 10 or 20, 8, 10 years old, and rheumatic heart disease 10 and 20 years later, man. We're just in time for pregnancy. What is different? What is different about mitral stenosis? It is the biggest left atrium, the biggest AFib. RALS is not different. They all have RALS. Decreased pulse pressure? Yeah, whatever. Loud S1. You know why there's a loud S1? Because it's like the door being slammed. You have a stenotic valve, right? And what happens is that the valve normally goes like this, normally flops shut. Normally flops shut. Normally the valve flops shut. Now you get this creaky stenotic valve. It's only halfway shut when the ventricle contracts. Normally it's like this. Lub, contraction, shut, contraction. Now the stenotic valve goes, and it's halfway open when the ventricle contracts. So instead of the valve shutting like this, what happens, the valve is halfway open and the ventricle contracts. Bang! Slam the door, man. Ventricle contracts. Bang! That's a loud S1. That's a loud S1. What's happening is that the ventricle is contracting when the mitral valve is still open, and instead of flop, lub, bang! Loud S1. Opening snap. You see how that's in red? Why, it must be important. It's in red. The opening snap happens because it's the sound of the mitral valve opening. Unique, unique, unique. Unique, unique, unique. Unique, unique, unique. Unique, unique, unique. S1, S1, S2. S1, S1, S2. Well, what happens is that you have a person who has a unique opening in here. Opening snap, you have an opening snap, and then after the opening snap, you have blood squeezing past the stenotic mitral valve. You have blood squeezing past a stenotic mitral valve, and that is mitral stenosis. Blood squeezing past the stenotic mitral valve. Now, as the mitral stenosis gets worsened, does the opening snap happen earlier, or does the opening snap happen later? Does the opening snap happen earlier, or is the opening snap as it gets worsened? The opening snap happens earlier. The opening snap happens earlier. The opening snap happens earlier. Okay? So what happens? The opening snap happens earlier. What's different? Well, if the mitral valve is all stenotic, the left atrium gets large. So what do you see in an EKG? I see left atrial enlargement. Left atrial enlargement. I see left atrial enlargement. Why am I going to see a person who has right ventricular hypertrophy? Because of pulmonary hypertension. Pulmonary hypertension hypertrophies the right ventricle. The chest x-ray, I'm going to see the signs of an enlarged left atrium. I'm going to see the signs of an enlarged left atrium on a chest x-ray. I will see the signs of an enlarged left atrium on a chest x-ray. And the signs of an enlarged left atrium on a chest x-ray, straightening the left heart border. The signs of an enlarged left atrium on a chest x-ray, straightening of the left heart border. A second density can be seen behind the heart. And the left main stem bronchus, can get pushed up. The left main stem bronchus can be pushed up. the left main stem bronchus gets pushed up, straightening of left heart border, double bubble behind that ventricle. So that's the sign of the large left atrium. You see a double bubble. You see straightening the left heart border. You see lifting up the left main stem bronchus. The echocardiogram will show that this thing is thickened and stenotic and thick and a large left atrium and right ventricular hypertrophy. Wow. A medical therapy for mitral stenosis. What medical therapy dissolves out the stenosis? Well, there isn't any. There is no medical therapy to dissolve out stenosis. But there is preload reduction. There is preload reduction, and preload reduction, there is a preload reduction, and preload, there is preload reduction, and preload reduction will at least be sodium restriction and a diuretic. So sodium restriction and diuretic decreases the volume into the lungs. Will ACE inhibitors help mitral stenosis? No, because ACE inhibitors help with ventricular emptying. And this is a problem with ventricular filling. This is a problem with ventricular filling. Okay? This is a problem with ventricular filling, so therefore ACE inhibitors won't help. Will digoxin help with mitral stenosis? No, because digoxin helps with ventricular emptying. Digoxin will only help if there's AFib. So diuretics and salt-restricted diet are the two mainstays of preload reduction. They don't cure the disease, but they keep the volume out. A 27-year-old pregnant woman is developing progressive shortness of breath despite diuretics and salt restriction. I don't like giving a diuretic to pregnant women anyway, because diuretics can cause intrauterine growth retardation. Diuretics can cause intrauterine growth retardation. What will you do next in the management of this patient if the diuretics are being given? Well, I would do balloon valvuloplasty. Okay? Digoxin will only control the rate in AFib, but balloon valvuloplasty, you balloon the mitrals. You balloon the mitrals. You balloon the mitrals. And you surgically replace the aortics. You balloon the mitrals and you replace the aortics. So you balloon the mitrals and you replace the aortics. Now, commiserotomy is what we used to do before we had balloons. Well, why is a balloon better than a commiserotomy? Because a commiserotomy, the commissures, where they attach to each other, you have to open the chest to do it. So that's a little problem, right? Commiserotomy means I have to crack you open like a lobster, spread your ribs, slice your heart open, make cardiac carpaccio. That's not so good. Balloon valvuloplasty, 20 minutes, in, out, done. Fantastic, fantastic, fantastic. Ready? Balloon valvuloplasty was invented to keep pregnant women out of the operating room. Balloon valvuloplasty was invented to keep pregnant women out of the operating room. And that's what balloon valvuloplasty is for. Now, mitral regurgitation. Regurgitant lesions in general are caused by infections, infarctions, ischemia, anything that makes you dilate. As your heart gets ischemic, does it get more contracted or does it get more dilated? It gets more dilated. It gets more dilated. When you get infarcted, things only dilate. And when you dilate, it only regurgitates. Remember that dilation equals regurgitation. 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 So therefore, when you infarct, when you ischemic, you get dilated. So therefore, these due to abnormalities, that's a cute word, right? Abnormalities means ischemic heart disease. That's what we mean by abnormalities. It's not like, retain negative emotions or loneliness. It means ischemia. Ischemia. Okay? It dilates the left ventricle. Well, what does it mean? Due to abnormalities. It means ischemia. You're dilating. Dilating equals regurgitation. And this word about men greater than women, that's true, but that's cutesy. That's cutesy. That's saying ischemic heart disease is more common in men. Ischemic heart disease is more common in men. So, oh, look at this. That means that things are flowing backwards. That's not good. It's supposed to go the other way around. It's supposed to go from this way to this way. Oh, look at that. Look at that arrow. Let's do that again. Let's see that again. Oh. Oh. I don't know what it is, but it's going the wrong way and it's big. That's called regurgitation. And it dilates. It dilates the atrium when it regurgitates. Oh, look at those arrows dilating me up, man. Let's see those arrows dilating again. Oh, this is so much fun. It's all become clear there. It's regurgitating and dilating. Fantastic. So, oh, that's more regurgitation and dilation. Isn't that cute? Okay. So when you have a person who has mitral regurgitation and it dilates your apical impulse off to the side. Why? Because as the left ventricle dilates, it dilates laterally. Now, you may be saying, did he just say dilates the left ventricle? Did he say that? Maybe I misspoke. I don't know, it could be. Well, the answer is, no, it does dilate the left ventricle. Why? Because when the blood regurgitates backwards, then with the next beat, what happens, everything starts to dilate up and dilate up and dilate up. So what happens is that one of the major findings in mitral regurgitation is that when the ejection fraction decreases less than 60%, that is operative criteria, because regurgitant lesions should have a supra-physiologic increase in ejection fraction. It should be above normal because it's regurgitating backwards. It's like knowing your gas tank leaks. You fill it up always extra tippy top. Know it's going to leak. And what happens is that left ventricular end systolic diameter at the end of systole. How empty can I get it? I can't all the way evacuate it. I've got tenesmus as my left ventricle, an incomplete sense of evacuation. As the left ventricular end systolic diameter goes above 45 millimeters of mercury, time to replace or repair the mitral valve. Time to replace or repair the mitral valve. As the ejection fraction drops less than 60%, or left ventricular end systole. At the end of systole, how empty can I get it? Because of the regurgitation, the ventricle dilates. When it dilates too much, you got to actually replace the valve, because once a ventricle dilates all the way, what can be done to restore it to normal size and shape? And the answer is nothing. What can be done to restore it to normal size and shape? The answer is nothing. So you've got to replace it before it dilates all the way. You got to replace it before it dilates all the way. So, what is the difference between pan-systolic and holosystolic? What is the difference between pan-systolic and holo? Nothing. All the way through systole. All the way through. All the way through systole. And you get distended neck veins because that's part of the congestive heart failure. Now, the EKG is going to show dilated left ventricle. Left ventricle enlargement, left atrial enlargement, left ventricular hypertrophy. That's saying the same thing as this. That's saying the same thing as this. All forms of valvular disease give congestion and cardiac enlargement, okay? So this where it says chest x-ray shows cardiac enlargement and vascular congestion, that's all forms of valvular disease. The echo, wow, the echo will show dilation and decreased ejection fraction. What is the best initial test for all valvular heart disease? The echocardiogram. What is the most accurate test for all valvular heart disease? Cardiac catheterization. What is the best initial test for all valvular heart disease? The echocardiogram. What is the most accurate catheterization? That's all of them. Now, you have to choose one single therapy for mitral regurgitation. What is the one single most effective therapy for all of mitral regurgitation? We use diuretics, we use digoxin, we use ACE inhibitors. If those don't work, we use surgery. But the single most effective medical therapy is the vasodilator. The vasodilator, what it does is increase that ejection fraction, and the vasodilator ACE inhibitor, if you have a cough, ARB, if you can't tolerate either one, hydralazine, is the single most effective. More effective than digoxin, more effective than diuretics, more effective than anticoagulants. Anticoagulants, in fact, are only there if there's a thrombus or AFib. If there's a thrombus or AFib, if there's no thrombus or AFib, don't answer Coumadin or warfarin. Guidelines for selecting patients: anybody who's got symptoms, you do operations on. But even before they have symptoms, if the ejection fraction drops and the left ventricular end systolic diameter goes up, time to replace before you get symptoms. Once the heart dilates up in size, nothing can be done to restore to normal shape and size. When you've tried everything, replace the valve. Now, mitral valve prolapse is a type of mitral regurgitation. We don't know why people get it. Congenital. You have a problem, you don't know who to blame it on. My valves are loose and floppy. My valves are loose and floppy. Well, more common in females, that's true, as most connective tissue diseases are. Say extra floppy valve, no big deal. Extra floppy valve. Well, Marfan's and Ehlers-Danlos syndrome, other types of connective tissue disorders. Then remember, the most common presentation, even though it's mitral regurg, of mitral valve, you ready? I'm going to spit on the unit. Ready? Prolapse presents with pain, palpitations, and panic attacks. Mitral valve prolapse presents with atypical chest pain, palpitations, syncope, panic attacks. Why do you get chest pain with mitral valve prolapse? Why does that happen? I have no idea. I don't know. I thought maybe you would know, but I don't know. Deep ignorance. Auscultation. What's different on auscultation? This is mitral regurgitation. Mitral valve prolapse is mitral regurgitation. What will be different? What is unique? What will give me all the answers that I seek? What's different? Mitral valve prolapse is mitral regurgitation. Except mitral regurgitation does not have a mid-systolic click. Mitral valve prolapse has a mid-systolic click, then a murmur, and a click, and a murmur, and a click, and a murmur, and a click, and a murmur. A click and a murmur that gets worse with Valsalva and improves with squatting. Now, what is the hemodynamic effect upon the heart of a Valsalva? What is the hemodynamic effect upon the heart of a Valsalva? It puts decreased blood into the heart, less blood into the heart. What is the hemodynamic effect upon the heart of a Valsalva? Decreased blood into the heart. Standing, decreased blood into the heart. Valsalva and standing, decreased blood into the heart. Well, what is the hemodynamic effect upon the heart of squatting and leg raising? Increased blood in the heart. The bottom line answer is all left-sided murmurs will decrease in intensity with Valsalva and increase in intensity with squatting and leg raise. More blood, more murmur. Less blood, less murmur. All of them except mitral valve prolapse and IHSS, hypertrophic obstructive cardiomyopathy. All left-sided cardiac lesions. More blood in the heart results in greater murmur. Less blood in the heart, less murmur. More blood, more murmur. Less blood, less murmur. Except for mitral valve prolapse and IHSS, also known as hypertrophic obstructive cardiomyopathy. Mitral valve prolapse and IHSS do the opposite. They do the opposite. That's what the auscultatory maneuvers are for, by the way. The auscultatory maneuvers are for being able to tell this distinction. How do I tell the difference between mitral valve prolapse and the others? The response to Valsalva and squatting. Look at this thing. Arrhythmias and death. Why would mitral valve prolapse do that? I have no idea. Nobody else does either. But you can get endocarditis. And although the individual risk for endocarditis is extremely small, because there is so much mitral valve prolapse, it does being one of the most common, if not the most common risk factor for endocarditis. Do you need to give endocarditis prophylaxis if I'm getting all my teeth removed or if I'm going to have dental work with blood? Do I need to give endocarditis prophylaxis for mitral valve prolapse? And the answer is must be, because after all, I just said it's one of the most common causes of endocarditis. But the answer is only when there's a murmur, not just a click. Murmur, not just a click. Regurgitation and murmur, prophylaxis. No murmur, regurgitation, no prophylaxis. Click only, no prophylaxis. You can get calcified, but that's not as bad as the palpitations and the pain. Like all cardiac lesions, see where it says TIAs here? CHF and TIAs, which are very rare in mitral valve polyps. TIAs, TIA stroke, TIA stroke, TIA stroke, TIA stroke. All valvular lesions can cause TIAs and stroke. All valvular lesions could give you congestive failure. All of them. All of them. That's not different or unique. What's different and unique? Mitral valve prolapse, click, murmur. What's different and unique? Mitral valve prolapse, atypical chest pain and palpitations in young women. What's different and unique? What's the most accurate test? Well, the best initial and most accurate test is an echo and a catheterization, like all valvular heart disease. An echo and a cath, like all valvular heart disease. Oh, so you would catheterize? You'd do a catheterization? I didn't say I'd do it. But you just said it was the most accurate. Yes, I said it was the most accurate, but I didn't say I'd do it. It is the most accurate, but I didn't say I'd do it. The treatment. Do we need to give endocarditis prophylaxis if there's a murmur? Do we need to give beta blockers? And the answer is for the pain. For the pain, the palpitations, the panic attack. Beta blockers. You basically don't need to do surgery for mitral valve prolapse. So here's your idea of a prolapsing leaflet. It's gone back too far. It's gone back too far. It's gone back too far. It's going backwards. Here's a prolapsing leaflet, leaky backwards, leaky backwards, leaky backwards. I'm sure this is extremely clear. It's not that clear. It's hard to see. Aortic stenosis. The most common cause of aortic stenosis is what a drag it is getting old. Down, 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 down. It's a drag getting old. That's what they tell me. I am aging backwards, though, like Merlin the magician. So it doesn't apply to me. But for everybody else, it applies. The most common cause of aortic stenosis is that as we age, the calcium leaves our bones and enters our aortas. As we leave, the calcium, leaves our bones and enters our aortas. As we age, the calcium leaves and basically gets calcified as you get older. There's 3 presentations. Syncope, CHF, and angina. What is the most common? Syncope, CHF, and angina. And the most common is angina. Syncope, CHF, and angina. The 3 presentations with aortic stenosis. Syncope, CHF, and angina. But the most common is angina. As we age, we calcify. And as we calcify, we get aortic stenosis. It makes it worse. As we calcify, we get aortic stenosis. It makes it worse. As we calcify, we get aortic stenosis. Now, rheumatic, you notice it's all the way down the bottom, but rheumatic fever can cause any of them. Any of them can be rheumatic fever. It's just that rheumatic fever most commonly causes mitral stenosis. Rheumatic fever can cause any, but the most common is mitral stenosis. Syncope, CHF, and angina. Syncope, CHF, and angina. What is the most common? Angina. What is the worst prognosis? Syncope, the CHF, or the angina? Which of these gives the worst prognosis? Congestive failure. Once the heart starts to dilate up, what can be done to restore it to normal size and shape? Nothing. Once the heart dilates up. So what happens is that initially you have this stenotic aortic valve in the way of getting blood out of the ventricle. And what happens at the beginning is the ventricle gets hypertrophic and starts to get big and thick and muscular. So what happens is the ventricle gets big and thick and muscular. Yeah, because I'm pushing against this much aortic valve. Yeah, I'm getting very big and beef and muscular. Yeah, And that's why you get angina. You get increased myocardial oxygen demand, greater left ventricular size, greater left ventricular thickness, greater left ventricular mass, more demand. More demand. Now what happens after a while? Left ventricle says, yeah, I'm very big, I'm very buff. What's the right ventricle doing? Right ventricle's not doing anything. I'm doing all the work. I do everything. I have all the pressure, I have all the work, and you're not doing anything. I'm going to become as big and fat and lazy as you, your right ventricle. And what happens is that eventually the left ventricle dilates up in size. The left ventricle dilates up in size. Because eventually the actin and myosin filaments just stretch apart, you dilate, you regurgitate, and it becomes a bit of a disaster. And if you wait until that ventricle dilates, the person will be dead in a year. Aortic stenosis to the point of dilated cardiomyopathy has the same survival as metastatic cancer. You have to replace the stenotic valve before you all the way dilate. Replace the stenotic valve. It has a 12 to 24 month survival. What is the most common presentation of aortic stenosis? Angina. What is the most worst presentation of aortic stenosis? CHF. When it dilates up, you can't restore it to normal size and shape. When it dilates up, you can't restore it to normal size and shape. So therefore, you replace it beforehand. You see this word here, tardus et parvus? Tardus means late, like the word tardy. Parvus means diminished. The ventricle contracts. You've got this stenotic aortic valve in the way. Well, what about the blood that's all blocked here? Well, it makes the pulse small and late. Small and late. It makes the pulse small and late. Therefore, parvus et tardus, tarvus et pardus. Thrill, a thrill, a thrill. Parvus et tardus, tardus et parvus. A thrill is a palpable vibratory sensation of a murmur. When a murmur becomes so intense that actually sets up a vibration, you can feel it. That's a thrill. That's a thrill. Now, the murmur is heard in the second right intercostal space. The murmur is heard in the second right intercostal space. The murmur is heard, let's see, A, P, T, M, apartment M. Apartment M. Look at this. These are the auscultatory areas. A, P, T, M, aortic, pulmonic, tricuspid, and mitral. Aortic, pulmonic, tricuspid, and mitral. Apartment M. Apartment M. Aortic, pulmonic, tricuspid, and mitral. Aortic, pulmonic, tricuspid, and mitral. Now, S4 gallop, what does it mean when you see an S4? Left ventricular hypertrophy. Left ventricular stiffness. Decreased compliance of the left ventricle. Left ventricular hypertrophy, S4 gallop. Left ventricular stiffness, S4 gallop. What do you do differently based on the S4 gallop? Nothing. You would have treated the hypertension anyway. S4 gallop is atrial systole, banging in the ventricle. But we don't do anything differently based on it. Everybody with left ventricular hypertrophy has it. Now normally, the S2 is split. A2, P2. A2, then P2. Aortic, pulmonic. Aortic, pulmonic. Well, now the aortic is so delayed that the aortic goes delay. Oh! Pulmonic, aortic. Pulmonic, aortic. So instead of A2, P2, A2, it sounds like this. Brr, brr, brr. Now it becomes brr, brr. You just have to know what it sounds like. You don't actually have to know how to hear it. No human being I know can actually hear this. So that's why in the sights and sounds of physical diagnosis flashcards preparing for the multimedia, we don't actually play a tape of it. We just describe it to you because you don't have to know how to hear it. Now, when people have aortic stenosis, the EKG shows left ventricular hypertrophy like everybody else. EKG does not diagnose it. They all can give cardiomegaly. They all can give congestion. Do you see how this is saying the same thing over and over and over again? We have said hypertrophy and congestion for every one of these valvular heart diseases. We said it 4 times. Hope we got it. Now the difference is there is no good medical therapy. You can use diuretics. You can lose a little preload reduction, but it basically comes down to this. They use a diuretic while waiting to take someone to the operating room. Ready? Aortic stenosis. Aortic stenosis is a surgical disease. When you're symptomatic, surgical replacement. When you need prophylaxis, okay, does it count as a significant lesion? Yes. Aortic stenosis is a surgical disease. Aortic stenosis is a surgical disease. Okay, aortic stenosis is a surgical disease. That means diuretics might be okay, but you have to remove it. Balloons don't work for aortas because aortic stenosis is calcification, and you can't balloon calcium very well. Aortic stenosis is calcification, and you can't balloon calcium very well. You balloon mitrals because they're fibrosis, but you replace aortics. There's our normal aortic valve, 3 cusps. There it is, 3 leaflets, beautiful shot. There's our crappy stenotic valve. There's our crappy stenotic valve. Let's see that again. 3 cusps, now crappy and stenotic aortic valve. That's it for aortic stenosis. Our next disease is aortic regurgitation. Now, aortic regurgitation, as the heart dilates, the leaflets separate. So you regurgitate. Now, it is true that things like, ankylosing spondylitis and syphilitic aortitis and endocarditis can cause these things. But if you take these things, endocarditis, syphilis, ankylosing spondylitis, Marfan's, add them up all together and multiply them by 10. It's not as common as regular old-fashioned ischemic heart disease and dilation. Old-fashioned ischemic heart disease and dilation is more common than all of them put together multiplied by 10. Ischemia makes you dilate, dilate makes you regurgitate. Dilation equals regurgitation. Dilation equals regurgitation. Aortic trauma, dilation equals regurgitation. Okay? So, therefore, the findings of physical findings here is congestive heart failure, makes you short of breath. Oh my goodness, what a revelation. It's the same as all of them. But there's a lot of unique physical findings for aortic regurg. Now, why is it that the boards are going to decide to add audio and videotapes? Why have they added this to multimedia? Because even though you may not see it and you may not know how to do it, they still expect you to know how to do it. They expect you to know that you're going to have things like a diastolic murmur, and it's going to be lub, dub, and after the S2 is going to be a diastolic decrescendo murmur. Diastolic decrescendo murmur. A diastolic decrescendo murmur after you have S2. You're expected to be able to know how to auscultate that. And they can play you a murmur of that. Bub, 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 and you'll be expected to recognize it. Now, a flow murmur, that's any cause of increased flow, no big deal. Now, these things about oddball signs, Drew Rosier's sign, oh my God, there's nothing more painful than things that are eponyms. Because what does that mean, de Rosier's? Did I de Rosier's today? Well, it's a guy who tried to achieve immortality by describing a murmur over the femoral arteries from aortic regurgitation. Quinky pulses in the fingernails, venous pulsations in the fingernails, water hammer pulses. Remember what a water hammer is? It's what they used to use to generate energy 140 years ago. Well, water hammers don't exist anymore. Water hammer pulses, de Rosier's sign in the femoral area, Quinky pulses in the fingernails, Demus's sign in the head bobbing. You'll never see these. You'll never see these because those valves get replaced surgically before a patient ever develops a head bobbing, Quinky pulsing, water hammering, de Rosier'sing. Those valves will be replaced. Nevertheless, you can be played this murmur and it says, what is that? The diagnosis, All valvular heart disease will show left ventricular hypertrophy. All valvular heart disease, the best initial test is a echo, not the x-ray. The x-ray on all of these can show hypertrophies in the enlarged heart. Congestion on the chest x-ray. LV hypertrophy on an EKG. But the best initial test for a diagnosis is the echo. The most accurate is a catheterization. Now, regurgitant lesions are treated with ACE inhibitors, diuretics, and digoxin. ACE inhibitors, diuretics, digoxin. The single most effective therapy for regurgitant lesions is vasodilator therapy. Vasodilators. If it says which of the following, see here it says salt restriction, diuretics, vasodilator, afterload reduction. The most effective, it doesn't reverse it, but it delays the progression. It doesn't reverse it, but it delays the progression. It doesn't reverse it, but it delays the progression. Okay? Well, endocarditis prophylaxis. Endocarditis prophylaxis means that when this person has a significant defect, which aortic regurg is, the person's going to get endocarditis, amoxicillin before dental work, or clindamycin if you're penicillin allergic. Amoxicillin if you're to dental work, or clindamycin if you're penicillin allergic. When do I replace that valve? Well, we said that the replacement criteria for mitral regurgitation as the ejection fraction decreases. Well, it's the same for aortic regurgitation, but in aortic regurgitation, it's an ejection fraction less than 55% and a left ventricular end systolic diameter greater than 55 millimeters. Aortic regurg, 55-55. Here it's 60-45. Regurgitant lesion, you're a little more liberal. We want to replace you when you're not quite as sick. So you can make it so it doesn't get any worse. You replace it or you repair it. Now that's it for valvular heart disease right now. And remember, the hardest thing about valvular heart disease is how to do the auscultations. Because unless you've done them, oh my God, how do you do this? You have to listen with somebody. Now, all the major textbooks of medicine, all the major physical exam volume, I should say, textbooks of medicine, have CDs and various things that you can download that play all the murmurs for you. So there's plenty. Now, my particular work on the Sights and Sounds of Medicine, on the physical findings flashcards, they have a selective few based on what you're most likely to be tested on. But any textbook, whether it's Bates or Schwartz or any of the others, has CDs and mini CDs that will play all the auscultatory maneuvers for you. Actually, or you can just get a book exclusively on auscultation. So that's not hard, but you do need to expect to be able to recognize the four most common murmurs as the four most likely things that you're going to be presented. It'll be a clear example. You just have to be able to recognize it. That's all. Now, the last part about valvular heart disease is I want to re-emphasize the subject of auscultatory maneuvers. This is something that's very hard to get, except let's make a point here, okay? The point is that people who have a Valsalva puts less blood in the heart. Standing from a squatting position puts less blood in the heart. Squatting puts more blood in the heart. And leg raising, what if I can't squat? Puts more blood in the heart. All auscultatory maneuvers can be divided into these two things. Is it put more blood in the heart or less blood in the heart? More blood in the heart or less blood in the heart? Stenotic lesions, mitral stenosis, aortic stenosis. Stenotic lesions, mitral stenosis, aortic stenosis. Mitral regurg, aortic regurg. Let's see here. More blood in the heart gives you more murmur. Less blood in the heart gives you less murmur. All left-sided lesions, more blood, more murmur. Less blood, less murmur, except hypertrophic obstructive cardiomyopathy and mitral valve prolapse. These murmurs do the opposite. These murmurs do the opposite. I hope you're not colorblind at this time, because then the reds and the greens are not going to help you as much. So, the maneuvers are the opposite. The maneuvers are the opposite. The maneuvers are the opposite. Okay? The maneuvers are the opposite. Okay. So therefore, stenotic lesions. Now you see, what is Valsalva in standing like? It's like giving a diuretic. Diuretics make all of these good. Good. Diuretics for these lesions? Bad. Evil. Diuretics. Well, the maneuvers are the opposite. The treatments are the opposite. What's the best therapy here for regurgitant lesions? ACE inhibitors, vasodilators. Which of these gets a vasodilator? Neither one. These both get beta blockers. These both get beta blockers. Beta blockers. Which of these gets a beta blocker? Nope. You balloon the mitrals and you replace the aortics. So what we see here is that the maneuvers are the opposite and the treatments are the opposite of each other. More blood, more murmur, less blood, less murmur, except for IHSS and mitral valve prolapse. There it is. And that's the way it is today in valvular heart disease. One other thing. Hand grip. What's the hemodynamic effect of hand grip? What does it do to your heart to hold my hand? Go on, take it. Squeeze me, squeeze. What does it do to do hand grip and squeeze the heart? Hand grip increases afterload. It's not a venous return. Hand grip increases afterload, and the opposite of that is amyl nitrate. ACE inhibitors work for regurgitant lesions. Amyl nitrate will make them better. ACE inhibitors make these better. Hand grip will make it worse. Hand grip is the anti-ACE inhibitor. So hand grip and amyl nitrate, hand grip increases afterload by compressing on the arteries of the arm. Amyl nitrate decreases afterload. Amyl nitrate decreases afterload by vasodilating peripheral arteries. And that's the final word on valvular heart disease. That's the way it is in the heart valve today. I wish you well. I'll see you in the next disease.